Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. Assalamu alaikum everyone. My name is Ahmed Hassan. I'm an addiction psychiatrist and a clinician scientist at CMMHC Center for Addiction and Mental Health. And I'm very happy to present this talk to you with my colleague, Dr. Amer Raheemullah, who will be joining us and talking to his part, following my slides. We'll start with the disclosure, which I have not. And I'll be presenting just a one learning objective after another. For the first one, we will discuss the common comorbidity that present in patients with substance use disorder, specifically trauma-related disorder. And as you probably might imagine and know already, that substance use disorder are very commonly presenting with additional mental health disorder. Usually the most common type of symptoms or disorder that we find with substance use disorder is depression. But it's also very common that we'll find substance use. Maybe I might reach substance use disorder level or might not, but it's important also to be aware of it in variety of mental health disorder. For example, major depression increases the risk of substance use by 2 to 3 times. The lifetime prevalence is about 60%, which can also increase the risk of suicide. Bipolar affective disorder, the mania and the depression, is by far from all of the mental health disorder has the most common substance use or substance use disorder, increased by 4 times. The risk and the lifetime prevalence is also about 40 to 60%. And as you can imagine, having both comorbidity, a mental health disorder, and a substance use disorder, usually, just to summarize the whole slide, is worse than having a single disorder by itself. Several line of evidence show that both of them, when they're present in an individual, they can lead to poor quality of life. A lot of severe symptoms, whether substance use or severe substance use, or severe mental health disorder. It will also lead to something we call medically treatment resistant. So if the treatment is not going as well in a person with substance use, we usually look for something else maybe behind it. And we've done a research study showing that childhood trauma or even PTSD can lead to that. And also the same thing, if we're facing difficulty in resisting the treatment that we're offering for a mental health disorder, it could be that the substance behind it as well. Polysubstance use, which means using 2 substances or more. Obviously that's not a good sign. That's very common when there's a mental health disorder, whether it's the result of mental health disorder or to try as a way of self-medicating these disorder. A lot of psychosocial problems, a lot of family problems, which we going to try to address in our second objective. And as a result of the severe mental health symptoms, you can imagine there's a lot of hospitalization, suicidal attempts, and possibly violence as well. Okay, in this slide, it might be a little bit complicated when you first take a look at it, but it just explains how the 2 disorders end up together. A very common way and also intuitive way to think about it, that a mental health disorder start, but there, for some reasons or a variety of reasons, including barriers to treatment, it was not treated or wasn't treated enough. Then a person get exposed to the substances, and as a result, they maybe started liking it because it helped with something. Now that's usually the case of trauma and opioid, for example. Although we hear a lot from our patients, and we learn from them that opioid, it didn't just take away the pain, but it took a lot of all the pain, like all the mental health pain, and that would lead to several continuous use, which can lead to the development of the substance use disorder. So it become a problem, and at the end of the day, it leads to 2 problems. The mental health is not resolved, and there's another problem with the substance use. But it also could lead to the other way around. If there's no mental health disorder in the beginning, a continuous use of substances, which can lead to when you use a medical term of substance use disorder, means substance dependence, or another name, addiction. Where we like lessly to we don't like to use that term very much. And then if there's a substance dependence, just by the nature of the substance, how it affects our brain and the physiological reaction, and also the negative consequences that it can lead in terms of social or occupation, it will lead to psychiatric symptoms, depression or anxiety. Very possibly, and also not uncommon that the substance use lifestyle would lead to a lot of high risk use, which can lead to severe exposure to trauma, and which also a big risk factor for a variety of disorder, and top of it, a PTSD, post-traumatic stress disorder, or other mental health disorder. And there could be a shared risk factor, such as the liability model or biopsychosocial, something like genetic. So an individual could face substance problem and later on faces a mental health disorder, but they could by the same factor. Usually the genetic by itself is a modest factor. It usually interacts with a lot of environmental factors that happen, whether social or occupational or interpersonal. And usually how they both end up together, and when you see them together in one person. We did a study that maybe explain a little bit about self-medication. Just this is one I'll emphasize on it because it's pretty common. We looked at the patient with PTSD, and then we compared them. We matched them actually with a control group who did not have a PTSD on a lot of factors that could be a risk factor for substance use, such as age or sex or previous substance use. And then and then we kind of epidemiological, that means like using some statistical method, we followed them before their exposure to opioid, both PTSD group and control. And after the exposure to opioid, as we expected, that the group in the PTSD were high risk for developing an opioid use disorder after exposure. This is again important of how the education is very important for a healthcare provider and also from a patient perspective, because you want to know that there might be a risk here if I continue using that, and it's helping with other things that I'm not aware of. Addiction usually have a lot of stigma in the general public, but a person could be feeling that they may be evaluating themselves or judging themselves as a weak or something wrong with them. But that's even more stigmatizing in the Muslim community by a lot of social and normative factor, because any addiction usually is totally forbidden in the Muslim population or by Islam. They might feel rejected from their own community. They might feel alone, not able to speak about it freely, even with the loved ones, or even approaching a professional. They might fear judgment because of it. Another problem is the collective denial, especially from an elder age group. So they might feel because of this like strict forbidden of substance use, that it doesn't exist in the Muslim community, and that's not exactly true. And therefore they will not be educating themselves a lot very much about what it might cause and what's the consequences. And if it happened that one of the family member that was affected by it, the expectation might be too high, and that can lead to a lot of problems as well, which we might be referring to in a bit. And then stress, major and minor trauma. So a lot of Muslims came from countries where they're affected, unfortunately, with violence or war or displacement. And that can be a major risk factor for to develop again a mental health disorder such as PTSD or even major depression. And we just spoke about how these by itself could be a risk factor for continuous use of substance and development eventually of a substance dependence or substance use disorder. Their second generation might be also affected as they might be desperate to fit in, especially if they move from one country to another during their school age, and they have a need to make friends and be supportive. And if they felt there's a peer pressure, unfortunately, by a group that use substances, that might be a huge risk factor as well. Yeah, and also the minor trauma that I was referring to here is talking about a lot of Muslims came from countries where they got affected by systems. There's a lot of mistrust, and they might carry on this mistrust to the country where they immigrated from, which can be a problematic of opening up and trusting others and looking out for help when it occurs. I'd like to share with you a little bit of a research study that we did recently about prevalence and treatment utilization of substance use in the United States, and we use a nationally representative sample. So similar to the design I showed you earlier, there was not a big number of individual in that national representative sample that identifies as Muslims, but we had 372. And we compared them to similar to one-to-one another 372 from the general public that had again the same risk factor, so Asian, sex, and where they were born, and childhood maltreatment. And we wanted again to look at the prevalence and also compare the treatment utilization. And what we found is about 11% had alcohol or substance use disorder in a lifetime, and about 18% had tobacco dependence. As expected, the diagnosis of alcohol dependence or alcohol use disorder were much less, significantly less than mostly in the control group. The tobacco dependence was much higher, statistically significantly higher in the Muslim group out of the control group. There's several theories behind that, but I think because the prohibitions of tobacco is different than other substances, because this does not alter the mind as much as the other, which might be prompting a lot for use. In terms of the other substance disorder, they were equal prevalence and equal rate between Muslims and non-Muslims in the general public, which can, to us, it might be a little bit alarming. That means there's more use. And keep in mind the national representative sample that we use was conducted in 2013, so that's a decade long. So I'm expecting that this reach is a bit high by now. In terms of comorbidities, about 4% had PTSD. I'm talking about the Muslim group now, and 10% had associated anxiety, and about 15% had associated mood, which could include depression or bipolar. And in terms of treatment utilization, overall Muslim had actually sought more professional help than the control group. So that could be also the impact of the stigma and other associated also consequences by the substance use. They specifically sought help from family services, detox center, outpatient, therapeutic community, and 12 steps. So there's a big variety of the reach. However, Muslim group had lower functioning in the emotional scale than the control group. And we believe, or our hypothesis is that that's because of the stigma that's caused by it. So even though that we compared them to another control group who had the substance use disorder, they were scoring were worse in the emotional scale. One demographic risk factor that we found that the US-born Muslims were more likely to have substance use disorder than Muslims born outside of US, and that could be speaking about the effect of acculturation or trying to fit that we talked about. There was the issue facing Muslims. And this is from our study and other studies as well done in these areas. There's a lot of likelihood of struggling with addiction in Western culture. They usually like have delayed access to mental health. That's a lot of other research have found that, or underutilization of mental health services. But even if they reach out, like as we just saw, there's a lot of poor prognosis, which might be affected by several layers, including stigma. And a systematic review have found that 24 studies for Muslim, they showed that they expressed the need of liking the support of religion or facilitate treatment. And that's probably because how this is an important aspect of their life, and they want to utilize it to help to get them to recovery. So by now we covered the comorbidity, their prevalence. I got a little bit of an idea of how both can be initiated together. Now I'd like to discuss to you, like as I mentioned before, that there's a huge impact of the substances on Muslims specifically, including the psychosocial and impact in the family. Family play a very important role in most Muslim family, and therefore I think this learning objective would be very useful in identifying like how to support loved ones basically who suffer from this comorbidity. All right, I'll start with a case example, and let's call the mom Miss X, who she's a mother of two boys and a girl. She immigrated for Algeria, Aljazair. Her eldest son was in high school when the time of she immigrated, and initially, I think in the first few years, he was performing well academically, but then she started to notice a problem, specifically maybe poor academic performance and changing the behavior. Of course, like she was worried about him. I think she tried to get into the problem on what is it. After several tries, she was able to be successful, and she found out that he's using opioid actually, also peer pressured by his friends, and he realized that it was not. It stopped helping anymore, or the fun stopped, and he can't stop. She struggled in the beginning because she was trying to reach to a specialist right away. I think she tried to apply what she's supposed to do back home into here, and she faced a lot of difficulty, and then she started to go to a different treatment center. And every time she was shocked because she was not involved into his care. Even in the assessment, a lot of healthcare provider will stop her from coming into the assessment, or tell her much more and saying that her son is an adult, and there's a limitation to confidentiality. I don't believe that her son will also wanted to share much. So I think she was bugging him to have information even at home, which bugged him as well and bothered him, made him maybe crave more substances, and the vicious cycle has started. But she was able also to reach to some mothers, the close friends, and she felt that when I said here passively withdrawal like this, she felt judged by them, and she felt like they started withdrawn, and because of her son use. So basically, she felt all alone in the process. But then finally, she was able, after several trials, to get him in the right treatment. He started methadone. She started to see a psychologist, and then a Muslim psychiatrist, which was me. And then the treatment started, and he was doing very, very, very well for several years. Occasionally there would be a big fight. The father, it was unacceptable to him that he will have a relapse. Like how would you? And that would happen every now and then, and it would lead to a lot of fight, and then would lead the son to have more substance use occasionally. If you're a family member, maybe ask this way. Even if you're a healthcare provider and you get this question to how can you contribute to the well-being of individual with addiction, it's important to know that addiction is in the Muslim community are not new. They're present for a long time, even since the time of the Prophet, peace be upon him. And Muslims have responded to the problem in the community and it's even mentioned in the Quran many times. The two types of addiction: the substance use, as al-khamr or alcohol, and non-substance use, which is gambling, al-maisir. And therefore, so it's not just an individual problem; it's a community problem. And there is a narration by the Prophet Muhammad sallallahu alaihi wasallam, that the parable of the believer in their affection, mercy, and compassion for each other is that of a body. When any limb aches, the whole body reacts with sleeplessness and fever. And therefore, it's very encouraged in Islam that we help each other. And we try to rush to help each other as much as we can. It was even encouraged to help each other more than the worship itself, or like staying in the mosque. And there's another narration about that. And even by the time of the Prophet, his companion was always helping Muslims suffering from addiction with forgiveness, accountability, patience, and persistence. And we'll talk about these four later on. And one of the first thing that really helps, as I mentioned in the case example, is education yourself about addiction. There, you need to know what this will reduce the mystery of addiction. You will know what to expect, and it will also destigmatize it a lot. It will help very much in the conversation that you're trying to initiate with your loved one. And you see an actual, what happens is with the mother that we presented, it helped her a lot, and she was able to prevent a second tragedy. We have developed this CMAP, which is a Canadian Muslim addiction program, to be all inclusive for different people, whether families, individual with addictions, healthcare provider, or even imams, clergies. So if you want to learn more about it, just email the research assistant. I posted her email here. I want to learn about CMAP, or if you're a healthcare provider, you can just go into, just take a picture of this link and try to go into. We also provide culture or face sensitive training on assessment of addiction for Muslims. As this is very essential, that you need to avoid stigmatizing language, junkie, addict, and there is a clear hadith or a narrative that a man named Abdullah, he was struggling with alcoholism, and when the companion disagree, or they start calling him names, the Prophet ﷺ said, do not say that. Oh, sorry. Do not curse him or forbid Allah. I know, for he loves Allah and he also. And you always need to consider joining an organization, something like 12-step, which is present in the community for families, like Al-Anan. And these community really helps you, obviously, supporting those who deal with addiction, but you learn from each other. And you share a similar experience, which again sometimes can be even more valuable than reaching out to a professional. I'm not saying this should replace it, but it can be very, very valuable because they give you that tips. And when it's hard in a community such as, like, it could be the stigma is high. We heard about the case and how she felt judged by a close friend. Maybe some sort of you go to a professional where they share. They're trying to combine people who suffer from the same thing. That might be more safer place to share your experience and learn from each other. And then seek professional help. You start by looking where's the local detox, where's the rehab, where's the inpatient. And I know a lot of the time you already know where it is, but it's hard to get the individual to seek help. But be patient and be persistent. When you show them, okay, please, I got you this appointment, or try it, like this is a number you can call them, or this is a brochure where I found them. It just makes it easier, because he or she probably, this is going to be a hard step to do, and you're initiating the conversation, and you're also showing that you care for them, and this is something that's really needed. And it could talk a lot about your care for them. And then address your loved one self-defeating pattern. So when bringing this issue, you know that person, you know how they usually respond. So prepare yourself for what might be a behavior they respond. Are they gonna start screaming? Are they start yelling? Is there a person that they would love and usually they will listen to them and they won't get agitated? Is this the best time? Maybe I usually know that this is a stressful time and I can't talk about it. So just prepare yourself for different response that might happen. And if a response that you didn't expect it, you could just prepare. You know now about this behavior, and then start preparing for the next time. But really be persistent and preserve while you're setting boundaries. So it's important to offer emotional support, but know your limit. And do not like enable addiction. So obviously, don't give money or purchase them the drugs that will allow this. Don't allow them to smoke, like use or the substance in front of other kids. You will have to protect the other kids as well. So just know your limit, and while able to still provide in this emotional support. All right, and so how can you approach a loved one? So remember, try to deal with this 4 steps. So forgiveness, and this is highly encouraged in Islam. Allah Azza wa Jal, it said in the Quran, "Wal-Qadimin al-Ghayz wal-Afiyin nas." So those he praised those who restrain their anger and pardon people. Always always do good. And when you forgive, you just forgive what they've done. Don't try to bring the past. You've done this and this and this and that and that. Just try to forgive all of that that's gone in the past. Let's start a new chapter. Let's start a new page. That's what you have to do. But at the same time, you have to make them accountable. They're the one who have to change. So if everything is expected that everybody is doing around it, no change from the inside, then no much of change is going to be in the outside. And be patient. Again, this process takes time. It was a process to develop addiction or to develop substance use or any behavior addiction, and it will be a bit of process as well. Hopefully, less inshallah, but it will be a process to recover as well. And be persistent. Repeat your approach again for help. Healthy habits can be very important and can go a long way to improve the overall well-being. This is just a few of them, but there's more others as well, and it can be customized according to the person that you're trying to help. One of them is daily journaling. This can provide a lot of safe place to document their journey, thoughts, struggle, daily success, and the keywords. In general, you can use a relaxing emotion words like spa and see, but in Islam, is highly emphasized to use what we call zikr or remembrance of Allah. So something like Alhamdulillah, which means thank God, or Astaghfirullah, asking forgiveness from Allah, or Subhanallah, magnifying Allah. These are very common, and probably the individual is saying it several times a day, but it can be used as a way also for encouraging emotional well-being. And in Camish, we have several programs like mindfulness or a mantra program, which can specifically design to help people with substance use and trauma related disorder as well. So, in summary, addiction is considered a big taboo in the Islamic culture. But you can start by help, but it happens and it's very common. The individual can be affected by them for a variety of reasons. And you can start by helping a loved one or family member by education yourself. So education is very important to help in destigmatizing the whole thing in the entire culture. Just because one approach does not work with another, does not mean that every other approach does not work. And relapse as well. Like, don't lose hope by the relapse. Keep hope in Allah mercy, and just like we saw with the father that he was expecting a lot from the son. To always be patient and be persistent. Don't forget to make dua or supplication to Allah Azza wa Jal, because in all of this approach that we're talking about, it will not help without his guide. So ask him first, and then you will see how, and then obviously do your effort and do your work, and all of this should be pay well, inshallah, later. And yeah, and then the goal of complete abstinence, sometimes it can be very hard to achieve in the beginning. So a harm reduction approach might be suitable as an alternative. And this harm reduction will really look very different from an individual into another. When you take your loved one to a professional, they will able to help you like customize basically one to it, but it's mainly using the less harm. So if a complete abstinence cannot be done, then what can be done? What can be prevent other consequences? So while the use is still ongoing, there is less psychosocial and even medical and health impact of it until it happens. And it will happen, but you just have to keep your hope up. Yeah, and remember to be compassionate and try to help your loved one by seeking treatment. And I think that's it for my part.
Bismillah, alhamdulillah, wa salatu wa salam ala rasulillah. So just to continue, I have no conflicts of interest to disclose. And our agenda for today, I'm going to go over a quick introduction, and then we'll talk about spiritually responsive assessments, talk a little bit about case examples, and then go from there, inshallah, and then talk a little bit about strategies for integrating spirituality. Okay, inshallah. So our primary goals are going to be talking about spiritually responsive assessments. What that basically means is we want to describe strategies for a spiritually responsive assessment of Muslim patients presenting with substance use disorder. And what's interesting is the way substance use disorder presents in Muslims is a little bit confusing. So we work at a nonprofit organization which works with Muslims specifically with substance use disorders. We offer support groups. So one of the things that we see is when people present to the support group or in one of our platforms, substance use disorder tends to present in an interesting way. So the most obvious and outer layer of the onion, and it's kind of like peeling away at the onion. If you look at this image I have here, it's like a chaotic onion that you're sort of slowly peeling away at. But the most obvious and outer layer of this onion is substance use. So what's and of course what's glaringly discrepant is because the patient is Muslim, the substance use feels even more out of place. So you're wondering like what's going on here? Muslims don't use substances. So on the surface, when you're encountering this, it's natural to think, how did this happen? But what's interesting is as we work with Muslims, we find that bit by bit, we're able to slowly uncover more and more about this story. So in essence, family stress might be something that comes up, and we find out that, yes, family stress and the stress that they're discussing tracks really well with risk factors for substance use. And as we talk to them a little bit more, as Dr. Hassan mentioned, with the comorbidities, with mental health conditions, we see, yes, the mental health stress that they're talking about tracks really well with substance use. When we continue to talk to them week by week, then we talk and find out about access to substances. And we find out that, yes, they have access to substances that are really risky and would be considered a significant risk factor. And what's interesting is a lot of times we're seeing access to substances not from the outer community, but from within our own communities and family systems. So that's something, if you're in this field, to ask about and be curious about, to prove that to yourself. And after you get comfortable with your patients and build some rapport with your patients, it might be interesting because the story may come up weeks in where you find out, well, when did you start using substances in the first place? I think this is important because there's this idea that many families have and many providers have that we're sort of protecting from this outer threat, this outer community threat. And a lot of times it's important to acknowledge what are the sources of the issue in order for us to be able to attack it effectively. So access to substances. If I have an individual and I'm trying to get them to stop using substances, acknowledging and recognizing substances within the home or within the family system is going to be important. And as we continue to peel away at this chaotic sort of onion, we may find trauma. And as Dr. Hassan mentioned, generational trauma. So people coming from other countries, escaping things that are really traumatic. Some of them not so obvious. Some family members with substance use disorder, their parents may not really have the vocabulary to understand what that means. So the point is, and this is the point I really want to drive home, although it might seem a little perplexing at first, just wait and listen to your patients, your Muslim patients with substance use disorder. Their story will guide you. And after a period of time, you'll slowly peel away at the onion, and it might not seem so perplexing. And essentially, you want to get to the point where it doesn't seem perplexing anymore. And that just takes time and listening. Okay, so we're going to talk about spiritually responsive assessments, and then also with that, spiritually adapting services and treatment, integrating spirituality into treatment. So substance use disorder is a human problem, and it's helpful to sort of frame it in this way. Addiction is a human problem. It's been around since the ancient Greeks, at least been wrestled with since the ancient Greeks. There's a lot that's been talked about it in terms of ethics, morality, also in terms of behavior, human nature, so on and so forth. Addiction was addressed with the beginning of Islam as well. So it's not a new problem to Islam. Wine was a part of life in pre-Islamic Arabia. There's at least 100 words for alcohol-related beverages. Some scholars say many more. And it's all over Arabic pre-Islamic poetry. So the fact is it was a really important part of life. And the idea that Islam could intervene on a societal level and change that is significant. So it's a human problem, and the Muslim response in that early community was a very human response. After the first ayah came down in Surah Al-Baqarah about intoxicants, some people stopped, but some people continued. It wasn't outright banned at that point. The second ayah came down, more people stopped, but not banned, and some people continued. The second ayah, people were banned from continuing to prayer, from coming to prayer while intoxicated. So you almost see this increase in spirituality and this decrease in substance use and sampling sobriety. So they were banned from coming to prayer intoxicated. What did that mean in the early community? That was their sort of core spiritual practice. They would come together as a community. They'd have that accountability, structure, support, and then also have the ability to pray and connect in a very powerful way. The third ayah came down and it was banned, intoxicants, and there was wide acceptance of it. But still some companions struggled, as Dr. Hassan mentioned, and this was after the ban of it. So the point I'm trying to get across is they stopped, but through a gradual process of change and over time in a very human way. So it's a human problem. It's a human problem. Muslims were affected back then, and they're affected now. Muslims needed support back then, and they need support now. Like Dr. Hassan mentioned about the companion that Prophet was kept a connection with him and supported him through that. So you can almost look at it like a circle, like I have in the slide. The larger circle is the human circle. It's a human. Within that human, you have risk factors and you have protective factors. Where does Islam come in? Where does spirituality come in? It's a protective factor. So you have a small circle. If in somebody with an addiction, you're going to have a small circle. That's going to be their protective factors. That's going to be overwhelmed by their risk factors, which is the bigger circle. So, we're not going to go into risk factors. That's just out of the scope of this presentation, but the risk factors for substance use disorder are essentially the same for Muslims and for people who are not Muslims. Risk factors are essentially access to substances. If you're in an area with increased access, if substance use is more normalized in your community, in your family, amongst your role models, then that's a risk factor for developing a substance use problem. Also, stress. So different types of stress, trauma, life stress, growing up with stress in the family, marital discord, or parents with marital discord, mental health conditions, so on and so forth. So those are risk factors for developing a substance use disorder. Protective factors are sort of the opposite of that. It's a lack of access, so on and so forth. But one protective factor that's incredibly important is spirituality. Spirituality, in many studies, as we'll talk about soon, have been shown to be a protective factor against starting substances in the first place or experimenting with them, and also a protective factor from transitioning from substance use to addiction or substance use problems. So then we come and we talk about treatment. So what do we mean by treatment? Treatment is essentially strengthening one and reducing the other. So reducing your risks and those risks that are in your life now and strengthening your protective factors. So treatment is essentially building up your spirituality, building up all your other recovery capital and going to treatment. So getting mental health condition, treatment for mental health conditions, treatment for your substance use disorder. But the idea is this framework is important. It's not the Muslim is the larger circle, and then, all this stuff is happening within them. So you have a human, and Islam is a part of that human. And it's a protective factor when it comes to substance use disorder. And that spirituality is just that. It's going to be dependent on how big that circle is. So if spirituality isn't playing much of a role in their life, it's not going to be as strong of a protective factor. And with that framework, I wanted to talk about spiritual assessment. So this is a mnemonic. It's an easy to remember mnemonic, and it's a good introduction to a spiritual assessment in your patients. So, and as you use it and get more comfortable with having these conversations, you just build off of that, and it could be a little bit more unstructured. But HOPE stands for HOPE. So let's go through it one by one. By the way, when we think about a spiritual assessment, it's going to be in the broader scheme of our substance use disorder assessment, which is going to assess for psychiatric conditions, medical conditions, which are important if people have chronic pain, other issues that's important to keep in mind. Also, their social history is important to get. If there's substance users at home, and we create a great treatment plan for them and then send them back to that same home, all of our work is going to be significantly less effective. And then, of course, the substance use history, so length and frequency of their substance use, when was their last use, their risk for withdrawal. Within that larger framework, we can insert the spiritual assessment, because the spiritual assessment is going to tell us about their recovery capital, their spiritual capital, to be able to effectively treat their substance use disorder. Okay, so H stands for hope, strength, comfort. So with the H mnemonic, the H letter stands for hope. So you're not asking about religion here. You're asking about where the patient finds these things. So where do they find hope, strength, comfort? For some people, it might be Islam. Others, it might not be. But this is a great way to assess this in an open-ended way without sort of feeding answers or making them feel obligated to say something like, religion's important for me. Again, we want to get to the truth so we can have a realistic a view of how we can intervene on this. Always for organized religion. What's the role of organized religion in this patient's life? What's the role of religion? So it's helpful to ask what this means to them. And then as a separate question, what does it mean for their family? So these are two separate data points. What does religion mean to them? What does religion mean to their family members? And understanding both of these can be an important piece in order to piece together the whole overall story, because that can be two separate things, especially if you have a family member that's bringing in their loved one for a substance use assessment. You want to make sure you don't assume that what religion means to their family is the same thing as what religion means to them. And you want to try to refrain from any implicit assumptions. This is a hard one. It's hard for me, and it's natural. Having assumptions is expected and natural. You just want to be aware of them, so that so they don't operate subconsciously with you through you. What aspects of religion are helpful? That's a question you want to ask. And what aspects of religion are not so helpful? This is also important to get their idea of what their definition and conceptualization of religion is. What is sort of interfering with their life? And then also community. Are they part of a religious community? Do they pray Eid, Salah, Jummah, Ramadan? Like, what is their engagement? How many times do they go to the masjid in a year? Those are questions that get an idea of what this means to them and paint a picture for you to intervene on. The P stands for personal spirituality and practices. Okay, so now outside of religious practices, do you have any spiritual practices that help you personally? So spirituality, and we'll talk about this in a little bit, might just be an open word, more of an open concept for some people. And they might be able to generate some different answers based on that question. E stands for effects on medical care and end-of-life decisions. So in this situation, that's what it stands for in the mnemonic. But in this situation, we want to talk about addiction. How's that affected your religious practice or spirituality? So I'm going to talk about some case examples. Let's say these are archetypes of people that we commonly see. Let's say you have a young adult. Let's just call it 18 to 25. That's an adult. His parents are devoutly Muslim, and he doesn't really connect with it at this point in his life. And he's not really connecting with his parents either. He's in early recovery. He's made some progress in staying sober, abstinent from substances. But he's not close to Islam. And he's also just not thinking too hard about it. He's just taking it one day, 1 week at a time. So what are the questions we can ask this person? What are their sources of hope? So in this person's situation, he says friends are supportive. Making music is supportive. Music is a supportive way and a release for him in general. But what's interesting here is these are not religious sources of hope, but they are supportive for this individual, and it's important to keep that in mind. What's the O question? How does organized religion have a role in your life? Now, in this person's situation, no religious engagement currently, which is not too much, is not too aberrant. It's not too much of a shocker. So, what is the role of organized religion? Maybe nothing currently, but it's still a good question to gently and non-judgmentally pry about. So, for example, in this person's situation, they talk about their childhood, going to Sunday school, fasting in the month of Ramadan regularly, praying daily in the past, maybe not every prayer, but daily. And then parents are devoutly religious. Those are all important pieces of information. And then asking, what are your personal practices of spirituality? And the patient still has the patient says nature is something that they're interested in reconnecting with. But then also going to Ramadan. They might have some good memories around Ramadan or other things connected to the deen. Or maybe just spiritual talks, or there's somebody that they listen to on YouTube, or somebody that they listen to in their community that just gets to them or gets at them, resonates with them in a special way. So what's interesting here is this person still has a connection with spirituality that can be nurtured. And then E, how does addiction affect religion and spirituality? And what's interesting is in this patient's answer, he says he feels bad about it because it's disappointing his parents. So what's interesting here is the religion is somewhat connected with the parents. It's not affecting his spirituality. It's affecting his relationship with parents. Just something to notice and something to be curious about and interested in. All right, so now take another example of an assessment. Again, a archetype of something we see often. So hope. H stands for, what are your sources of hope? So this is a person, Islam was a positive spiritual experience in their life. It helped them in their sobriety. They've obtained years of sobriety. They had to move back to an old neighborhood recently, and they're struggling because substances are around that neighborhood, or people that they knew who they used in the past with are in that neighborhood. Now they're at a point where they're increasing their engagement in recovery work, and so they show up to your support group or show up to your treatment setting. You ask them, what are your sources of hope? Now, this person, spirituality is an important part in their life. They're saying prayer in congregation. They're going to a weekly dars on spirituality or deen. They're going to their Friday prayer. They're reading Quran. And then also doing some other recovery work, counseling, anger management classes, so on and so forth. What's interesting here is, unlike our previous example, the sources of hope revolve around spirituality and therapy. And then the second question, organized religion, plays a large role in this person's life. The third question, their personal practices of spirituality. What's interesting here is everything they say is synonymous with H. So spirituality in this person's life is a source of hope. And that's essentially that's the ideal relationship in terms of having it be useful for addiction treatment and recovery. And then how does addiction affect their religion and spirituality? Addiction affects it significantly. It's a tool for change, and it's a large part of maintaining abstinence. And I'm gonna keep the same example, but let's just say this person relapses. All the answers are the same, and all of their assessment points are similar, except now they might have a hard time reconnecting with spirituality. Maybe they've been on a relapse for weeks, maybe months. Now they're having a harder time reconnecting with spirituality, but it's really important to recognize that spirituality is an effective tool that they have. And they might just have a little bit of a harder time yielding it because of shame and stigma of the relapse and reintegrating into their old community. But there's two main points I want to make here. Number one is we really want to have a good spiritual assessment, because if we shy away from that or have some reservations about having this conversation, we may miss that really important tool that they have, and recovery tool that they have. And then number two, we want to play a role in helping re-engage them with this tool of spirituality that they have for their recovery and their treatment. Okay, I'm going to talk a little bit about treatment now, now that we sort of concluded assessment, and talk a little bit about treatment and how spirituality situates itself in treatment. So first, I want to make that claim that spirituality is treatment. So there's a really great study, references at the bottom. 73% of addiction treatment programs in the US include a spiritually based element, as embodied in the 12-step programs. And the vast majority, of course, of the 12-step programs emphasize reliance on God or a higher power to stay sober. The study also commented or showed more than 84% of scientific studies show that faith is a positive factor in addiction prevention or recovery. And there's many studies like this. And the point I want to make is that spirituality is not a detour from treatment. It's not something we're forcing into treatment. It's an essential component of treatment. And that's something that we should keep in mind. So when we think about treatment, here's some things that we tend to think about. We tend to divide treatment into these three dimensions based on the literature out there, and recognized guidelines: support groups, professional treatment like therapy, counseling, and addiction treatment programs, residential programs, outpatient programs, and then medications for cravings, and then also medications for withdrawal, or both. Now, spirituality is something that can be integrated in all of these, and sometimes don't need to be integrated. They're already a essential component of some of them, like let's say the 12-step programs. But for example, with support groups, spirituality can be integrated in support groups. You can create support groups that are spirituality or spiritually based, and or you can integrate spirituality into your group therapy, depending on what your audience is or who your group members are. We'll go into the end of some of these interventions that are available or that have been done, so that people can get an idea of how they can recreate that in their own communities, or get ideas of how to recreate that in their own communities. And then professional treatment. So spirituality should absolutely be a conversation, therapy, and counseling, and can be integrated in these areas as well. And then also medication management visits for buprenorphine, methadone, and other medication for substance use disorder. We have a lot of time in these medical visits in order to have conversations and integrate counseling and spirituality assessments, and then also spirituality. All right, so how do we have these conversations? Once we assess, how do we intervene? I think it's important to look at the stages of change model and remember that the stages of change are not just for substance use disorder. It's for any goal. So like we discussed the treatment dimensions before, the stages of change are really applied to that treatment. So for example, if somebody needs a residential program, let's say they're homeless and this is clearly the choice that they need in order to gain any traction in their substance use problem. Let's say they're super motivated to stop using substances, but you as the professional say, no, you need a residential program. You're just not going to be able to do it on your own, or you need some treatment. That patient can say, I'm in the action phase for in the stages of change, but really not in the action phase for any realistic plan for treatment. That patient's not in the action stage. We would consider them pre-contemplative or contemplative in terms of their stage of change, for their stage for change, for any realistic change. So the point I want to get across here is that the stages of change model is not for I want to stop using substances or not. It's for what treatment are you ready to commit to or take action on. So what is the patient's stage of change for a treatment program? What is the patient's stage of change for meetings? What is the patient's stage of change for spiritual intervention, for spiritual interventions? So you can use the stages of change model, and it's a good model to use also in trying to get an idea of where they're at in terms of their spirituality. So for example, when you have your patient who, in our first example, born into a Muslim family, still Muslim, but just not in a place where they're thinking too hard about about spirituality, you can put them in one of these stages of change, because again, spirituality is treatment. And again, stages of change are sort of the industry standard of how we counsel and motivate people to enhance their motivation towards treatment. And so you can put your patients in terms of their engagement in spirituality in one of these stages as well. So let's go through each stage one by one, and then we can sort of apply it in terms of how that makes sense for treatment as well. So in the pre-contemplation stage, the patient does not recognize they have a problem with substances and are not ready for treatment or changing their behavior. In the same way, you can, for Muslims, they might not want to talk about Islam. So they might be pre-contemplative for any treatment, including spiritual interventions or integrating spirituality in their life. So just like they're pre-contemplative about their treatment program, they can be pre-contemplative about their wanting to integrate spirituality and Islam in their life. So what's important here is that your goal here isn't to get them into a treatment program. Your goal is to get them into the next stage of change, so contemplation. So first we want to understand where they're at in their stage of change, and then we want to employ a well thought out intervention to get them to the next stage of change. At the bottom, there's a reference for a motivational interviewing handbook. There's many handbooks out there. This handbook I like because it's developed based on the stages of change. So you can quickly look, is my patient in pre-contemplative or contemplative or preparation stage? And how do I get them to the next stage, and just employ 2 or 3 interventions in that visit you have with them in the group therapy, or that visit you have with them in the medication management visit, so on and so forth. So it's a practical way of using this. All right, so that's the pre-contemplation stage. So the contemplation stage, this is a patient that wants to change. They're starting to acknowledge that their substance use has consequences. But in this stage, they'll still be ambivalent about change and how to take steps towards that change. Maybe they just lack confidence in their ability to change. For Muslims thinking about spirituality, they may be concerned about their lack of engagement in religion. It sort of got away from them. How do they get to this point? That might be the thoughts that are going into their mind. So just like you can work on moving to the next stage of change in terms of getting into a treatment program, you can employ those same interventions. They're flexible to spirituality or any treatment intervention. Okay, so then there's a preparation stage where patients have been learning about treatment options, but not yet started to implement their plan. They're still ambivalent, and they're waiting for an opportunity to nudge them in that direction. You can apply that for their engagement in spirituality and Islam as well. Next stage is action. They're actively changing their behavior, but they're not yet settled into that behavior. Once they've been doing it for months, then we consider them in the maintenance phase. And all these stages of change, I'm not going to go over them, but all these stages of change also have interventions associated with them. You can look at the reference at the bottom to see what those interventions are. But you want to create a effective, realistic model of how to integrate spirituality, whether it be in the clinic setting, group therapy setting. And this is a way to do that. Number one, by not conceptualizing spirituality as this other thing from treatment. It is treatment. Number two, then seeing what stage of change your patient is for treatment, whether that be a treatment program, whether it be 12-step meetings or other support group meetings, whether that be spirituality. And with each of those interventions, you assign a stage of change for that, and you treat it accordingly. And if they're contemplating spirituality, then you employ a motivational interviewing intervention to get them to the preparation stage. You get them from the preparation stage. If they're in the preparation stage, you do likewise to get them to the action stage. And each of these have an intervention. So I am going to look at a couple of these. So preparation stage, you want to focus on maintaining a connection and an alliance with the patient. You're not going to make headway into getting them to change overnight, and you're going to be very frustrated if those are your goals. You want to make smart, attainable goals. Contemplation stage, you want to focus on normalizing the fact that they kind of might want to be going and engaging in some Islamic things, but then kind of not wanting to, and then helping them normalize their ambivalence in that way, and so on and so forth. Spirituality and religion, these are words that are used as two separate words in the recovery rooms and just in the treatment culture. And they're basically the same thing, but they're different dimensions of the same thing. The meanings to the patient are more important than any words. So you just want to use what words your patients are more open with. And then finally, Islamic spirituality is, what is Islamic spirituality? Islamic spirituality is something that's learned through groups, classes, dhikr gatherings, through education, and so on and so forth. And then it encompasses the body, mind, soul. There's a sunnah of eating. There's a sunnah of sleeping, how to take care of yourself. There's a sunnah of how to reframe your mind in a meaningful way, how to find meaning in suffering, how to cultivate gratitude. And then there's obviously a spirituality of how to feed your soul. And then I'm going to end with this. These are a lot of really amazing initiatives that are happening in our community. Overcoming Addiction is a book by the Thayba Foundation, which talks about how to integrate the 12 spirituality into the 12 steps. And it's really wisely just done. And it really tracks on the recovery journey that people have. There's another book, Loving the Present, by a Muslim sister who talks about her experience in recovery. There's some rehabs out there that are Muslim-led or integrate Islam into their treatment. Tranquility Rehab, Salam Recovery. There's a sober living home through Hype Athletics, which is a nonprofit organization. MCC East Bay, this is a masjid that is hosts 12-step meetings and has a lot of social media content on recovery and addiction for many different people on their YouTube channel. Stanford Islamic Psychology Lab and the Institute for Social Policy and Change are doing a lot of great research in this area. And then a big call out for the Center for Addiction and Mental Health. Their website is at the bottom. This is a Canadian organization, and Dr. Hassan mentioned it. I'm going to mention it again. It has a lot of really great stuff there. So check out that website. And then Militi Islam is something that has been around for a long time, which incorporates spirituality to the 12 steps.